Hi everyone, my name is Faustine Ramirez and I'm a master tutor with MedSchoolCoach. So today we'll be reviewing a Step 2 CK Pediatrics question. So let's start by reading the stem. A 2-year-old boy is brought to the pediatrician's office with 3 days of fever, fatigue, and productive cough. He completed a course of antibiotics for acute otitis media 2 weeks ago and has had frequent episodes of otitis media and thrush in the past year. His mother also reports easy bruising with very minor injuries and frequent nosebleeds. He was born at term following an uncomplicated pregnancy and delivery, although his mother recalls he developed prolonged bleeding following circumcision. He also has a history of severe eczema since infancy. He appears tired and irritable, but is consolable by his mother. Temperature is 38.7, heart rate is 135, respiratory rate is 38, and oxygen saturation is 94%. On examination, he has mild sub-costal retractions and crackles are heard in the right lower lung fields. Multiple 1 to 2 centimeter mobile rubbery lymph nodes are palpable in the cervical chains, and there are white plaques on the tongue. An eczematous rash covers his face and body. A spleen tip is palpable 2 centimeters below the costal margin. Laboratory studies show the following. Which of the following is the most likely diagnosis? So I'd like you to pause the video for a moment and try to work through this question on your own first. All right, welcome back. So let's start by approaching this question, and the first step is going to be to read the actual question itself. So which of the following is the most likely diagnosis? So this is going to be a one-step question where we just need to read the question and identify the most likely diagnosis. So often the simple diagnosis questions where it's just one step instead of two-step questions where you have to identify the diagnosis and then answer a question about it, oftentimes we will get some questions that are just asking you for the diagnosis, and these tend to be harder diagnoses to make, as opposed to more common diagnoses where you need to know more about the management. So we glance at the answer choices, and we see that we are in an immunodeficiency question. So these are often found to be difficult for students because there are a lot of immunodeficiencies in pediatrics and you have to know the specifics about the presentation for each of them. But hopefully after this question, you'll feel a little bit more comfortable about how to approach immunodeficiency questions. So we look at these and we see they involve a number of B cell, T cell, and combined immunodeficiencies. So we'll have to keep an open mind as we're reading. So let's read this question from the start. So a 2-year-old boy is brought to the pediatrician's office with 3 days of fever, fatigue, and productive cough. He completed a course of antibiotics for acute otitis media 2 weeks ago and has had frequent episodes of otitis media and thrush over the past year. His mother also reports easy bruising with very minor injuries and frequent nosebleeds. He was born at term following an uncomplicated pregnancy and delivery, although his mother recalls he developed prolonged bleeding following circumcision. He also has a history of severe eczema since infancy. He appears tired and irritable, but is consolable by his mother. Temperature is 38.7, heart rate is 135, respiratory rate is 38, and oxygen saturation is 94. So he's febrile, a little bit tachycardic, tachypnic, and hypoxemic. On examination, he has mild sub-costal retractions and crackles are heard in the right lower lung fields. Multiple 1 to 2 centimeter mobile rubbery lymph nodes are palpated in the cervical chains, and there are white plaques on the tongue. An eczematous rash covers his face and body. A spleen tip is palpable 2 centimeters below the costal margin. Laboratory studies show the following. So before we even get into these labs, I'd like to point out a few things. So when we're approaching an immunodeficiency question, the first step is going to be to identify whether this is a B cell dysfunction, T cell dysfunction, combined B and T cell, or a phagocyte dysfunction. So I want you to think about when you're approaching immunodeficiency questions to always think about your main buckets, right? Because that really narrows down the differential. It goes from having a list of 15 immunodeficiencies to pick from to really only maybe up to 3 or 4 within each category. And some categories don't even have that many, right? So you can think about within your B cell dysfunction, there are 4 diagnoses you need to know. Within T cell, there are 2 or 3. Within combined, there are 2 or 3. Phagocyte, there are about 3. And so that really narrows it down. So the first step when you're approaching an immunodeficiency question is to identify which of these buckets we're falling into. And so to do that, we need to look at the type of infections that the patients are having. So if it's only bacterial infections, you should be thinking about B-cell dysfunction. If it's only viral or fungal, you should be thinking about T-cell dysfunction. If it's all types of infections, viral, bacterial, and fungal, you should be thinking of a combined B and T cell dysfunction. And then the phagocyte dysfunctions have very specific characteristics, and so those are kind of their own separate category, and those have very classic presentations. But those often do have a tendency to involve more bacterial infections, and so when you do see a lot of bacterial infections, you should also be thinking about the phagocyte dysfunction. And so then you'll look at the other defining features and see if it's more consistent with the phagocyte dysfunction or with the B cell dysfunction. So just bacterial, you still have a few more options. But in this case, we have a combination of bacterial with otitis media and the previous episodes of otitis media, and now this current presentation, which putting the pieces together with fever, cough, hypoxemia, and some mild respiratory distress, that's consistent with the pneumonia, especially with the crackles in the right lower lung fields. So although the question is not about identifying what the specific infection is, you should be able to put together those pieces to know that it's a pneumonia. So the combination of the otitis media and pneumonia, we have bacterial infections. We also have fungal infections. We're told that the patient has recurrent thrush in the past year. And although we're not specifically told that he's had any viral infections, a combination of the bacterial plus the fungal plus just the recurrent infections, we're thinking that we're in the category of a combined immunodeficiency, right? Because we have enough here to tell us that we're not just exclusively falling into B cell or not exclusively falling into T cell. We have some components of both, with both the bacterial infections and the fungal. So we're in a combined immunodeficiency here. And so within our combined immunodeficiency, that really narrows it down to about 3 or 4 diagnoses that we need to know about. So this is helpful. Another thing I want to point out is to kind of pay attention to the other features besides the recurrent infections. So when you're thinking about the recurrent infections, you want to look at the type of infection, like I mentioned, to help place us into a specific category of immunodeficiency. And then once we're within that category, we're going to have to use the other features of the presentation to identify which other immunodeficiency it is. And so we're going to be able to use findings in the history, we're going to be able to use findings in the physical exam, and then also lab findings. So let's go ahead and look at these labs and interpret them, and then we'll put together what the other features are. We'll pull out all the important features. So hemoglobin 12.5, that's normal. Leukocyte count 4,800, that's actually a little bit low. Platelet count 42,000 is also low. Blood smear with small platelet volume, that seems to be a little bit abnormal, so let's highlight it. Even though we may not know exactly what that corresponds to, it seems a little abnormal. And then we have our immunoglobulins, and on the exam you will have reference ranges for these. So we'll go through these together. So IgA 490 is on the high side. So we'll highlight that. IgE of 420 is also on the high side. And then IgM and IgG, these are actually on the low end of normal. So the next step, like I mentioned, once we've identified that we're in the category of a combined immunodeficiency, is going to be to identify what the other features are on history, exam, and labs. So pulling a few important pieces out. So once we look beyond the recurrent infections, because we've already used that to place ourselves in this category, and then we have to see what else is going on. So the other important things are that the patient has easy bruising and nosebleeds, prolonged bleeding after circumcision, and on labs has a platelet count of 42,000, which is quite low. So let's say this is, we're in the combined category plus bleeding, which is explained by the low platelet count. The other important finding here we're told is that this patient has a history of severe eczema. So this could be important. A lot of these immunodeficiencies have skin findings associated with them. The vital signs here are important because they clue us in that this patient is currently presenting with a pneumonia, but the type of infection here, we've already identified what category we're in, so is less important. But there are some other findings on the exam that are important to notice, is that this patient has multiple lymph nodes in the cervical chain, so we'll say plus lymphadenopathy. The plaques on the white tongue, that's consistent with thrush. We're already told that this patient has a history of recurrent thrush, and that's consistent with being in a combined immunodeficiency. So we don't need to dwell on that further. We're told that he has an eczematous rash, that's consistent. And then the patient also has a spleen tip that's palpable. So your spleen tip should never be palpable. Sometimes you may feel a liver edge right under the costal margin. That could be normal, but a spleen tip itself should not be palpable. So we'll add splenomegaly here. And then finally, in terms of the labs, we have a low leukocyte count, and that could be helpful. So we'll add that here. So low white blood cell count, and then we have these different immunoglobulin levels, and we're shown that some are high and some are on the lower side. So I'm just going to put immunoglobulin patterns. And so this specific pattern of immunoglobulins is consistent with one of the immunodeficiencies, which we'll discuss further. So I would say these different patterns in terms of the immunoglobulins, different types of immunoglobulins is important. So now we're in the category of combined immunodeficiency, plus we have some additional features that are, besides the recurrent infections, that can clue us into which of the combined immunodeficiencies we're talking about here. So before we discuss this constellation, let's look at some of the other answer choices and see which ones we can eliminate based on what we've identified so far. So when you have these questions about immunodeficiencies and you know what category you're in, go ahead and cross out the ones that don't fit in that category. So primary HIV, that could be combined, so we'll leave it. Adenosine deaminase deficiency. So you may not know which one this is referring to, but you should. This is corresponding to SCID, which is severe combined immunodeficiency. This is one of the deficiencies that can cause SCID. So we'll leave that there. That could be combined. Hyper IgE syndrome. So this is a T cell deficiency exclusively, so we can cross that one out. Common variable immunodeficiency. This is a B cell dysfunction immunodeficiency, so we can cross that one out. Wiskott-Aldrich syndrome. This is also combined, so we can leave that one for now. X-linked severe combined immunodeficiency, that's also combined. That's the other type of SCID that you can get, so we'll leave that there. And then X-linked agammaglobulinemia, also called Bruton's. This is exclusively B-cell dysfunction, so we can cross that one out. So we're still left with 4 answer choices that all fall into this category of combined immunodeficiency. So the second step, as we said, was to look at the constellation of symptoms and to see which immunodeficiency it's consistent with. And usually, once you're in that correct bucket, you'll be able to identify the immunodeficiency based on the presence of these other features. Now, the key here is just to know which features are seen in which immunodeficiency. And so I would really encourage you, if you don't remember which of these immunodeficiencies have very specific other features on exam or on the history, to take a moment and to, after you review this question, to review the other immunodeficiencies and try to highlight what those other features are, because those are going to be crucial once you're in the right bucket to identify what the right diagnosis is. So here, the constellation of these findings of a combined picture in addition to bleeding, thrombocytopenia, eczema, and these other, even without these other features, just the combination of these first 3 things that is consistent with Wiskott-Aldrich syndrome. And these other features are additional details that if you knew them, that was fantastic, but if not, now's a great time to learn them, but they weren't necessarily required to answer this question. You could have gotten the question right just by remembering that the combination of a combined immunodeficiency with bacterial, viral, and fungal infections, in addition to bleeding, thrombocytopenia, and eczema, is consistent with Wiskott-Aldrich. So let's review Wiskott-Aldrich because it certainly could come up on your examination, and it has a few defining features that you should be able to recognize after learning this question. So the etiology of Wiskott-Aldrich, it's an X-linked defect in the actin cytoskeleton reorganization. And you don't need to know all the details. That's sufficient in terms of the etiology, but it does lead to both the combined B cell and T cell dysfunction. So this is going to present with bleeding, recurrent bleeding due to thrombocytopenia, extensive eczema, which often gets super infected, and recurrent bacterial, viral, fungal infections. So the bacterial infections tend to be otitis media, sinusitis, pneumonia, meningitis, the ones that are caused by strep pneumo, Haemophilus influenza, so some pretty common infections of infancy, as well as that plus viral and fungal infections, so recurrent thrush or other fungal infections, as well as recurrent viral, for example, upper respiratory infections or other viral infections. There's also an increased risk of autoimmune disorders and malignancy. And there are some additional physical exam findings that are bonus points if you know them, but definitely are not required to get the question right. So these patients often have lymphadenopathy as well as hepatosplenomegaly, which our patient had both splenomegaly and lymphadenopathy. But like I said, the combination of these three features is sufficient to get this question right. So there's a mnemonic that I use to remember these is water. So the W and the A stand for Wiskott-Aldrich. The T stands for thrombocytopenia. The E stands for eczema, and the R stands for recurrent infections. And so really these are the three main defining features of Wiskott-Aldrich. And if you see the constellation of these three findings, that's sufficient to identify Wiskott-Aldrich as the correct diagnosis. So thrombocytopenia and bleeding, eczema, and recurrent infections that are both viral, bacterial, and fungal. All right, so now let's quickly review the other lab findings that are, again, added bonus features if you identify them. You will get thrombocytopenia. That's part of the one of the core features. And the small platelet volume is actually a very specific finding for Wiskott-Aldrich. So if you see this, this is essentially a slam dunk, small platelet volume plus recurrent infections. You should be thinking Wiskott-Aldrich, very specific. You'll also get a decreased number and function of T cells. So this patient had a leukopenia. We weren't given the differential, but we could, be thinking that it was related to the decreased number and function of T cells. Although that, again, could be a relatively non-specific finding in an immunodeficiency, so not something to hang your hat on, but definitely contributes to the picture overall. And then more specifically in Wiskott-Aldrich, so you can get abnormal immunoglobulin isotypes. So your IgA and IgE tend to be high, and your IgG and IgM tend to be low to normal. And this level of detail, I would say, is fantastic if you're able to remember it. But I truly think you can answer this question just based on these findings that we had here, plus the thrombocytopenia with the small platelet volume. You could get this question correctly, even if you couldn't remember how the isotypes were different. You didn't need this piece of information to answer the question correctly. So really it was these three core features plus the thrombocytopenia and small platelet volume. This was a slam dunk without even remembering the differences in the immunoglobulin isotypes. And then finally, in terms of treatment, these patients often will need antibiotic prophylaxis. They may need IVIG and platelet transfusions based on their immunoglobulin levels and their platelet levels. They certainly will need antibiotic prophylaxis, but this is more supportive. The only curative treatment is a stem cell transplant. So looking back at our answer choices here, we had already crossed off hyper IgE because that's T cell dysfunction. We had crossed off G because that's B cell dysfunction. We had crossed off G because it's B cell dysfunction. And then we were left with A, B, E, and F, which were all combined immunodeficiencies. And so now that we've learned that this constellation findings was a slam dunk for Wiskott-Aldrich, we can look at the other ones very briefly. X-linked severe combined, that would be SCID. wouldn't have the eczema, wouldn't have the bleeding, wouldn't have those other features we discussed. ADA deficiency, also SCID, so again, wouldn't have these other findings. And then primary HIV infection also has some other features that are part of the constellation of primary HIV, including diarrhea, rash, mucocutaneous findings. So I would definitely review the presentation for primary HIV infection, but it does not include these findings of eczema and recurrent bleeding and thrombocytopenia. So that was not correct. So whenever you approach an immunodeficiency question, that first step should be to figure out which category you fall in, and that'll really help you narrow down the differential for the question, right? So you go from having a list of 15 immunodeficiencies to just 3 or 4 within that category, and you can use the type of infections to narrow down the category. And then the next step is to look at the other features. And so when you're learning these immunodeficiencies, focus on those other features. Is it eczema? Is it delayed umbilical cord healing? Is it certain types of abscesses? Is it certain type of bacteria that you need to know about? Are they catalase positive organisms or not? So what are those specific features that can help clue you in once you're within that category to which immunodeficiency it is? And so if you use this approach, although these questions are tricky, I think if you use this approach and you study those other features well and you focus on those in your studies, I think you'll be able to master any immunodeficiency question moving forward. So that wraps up our question of the week, and thanks so much for listening.